Welcome.
Oh, there's Katya.
Hi, Zach. How are you doing?
Well, thanks. How are you? Oh, hey, Raquel. Good to see you.
Good to see you.
How are things?
Well, pandemic things, you know, it's not easy, but we are doing pretty well.
All right. Good morning, everyone. I'm Genesis, the marketing director for the Society of Cannabis Clinicians. Thank you so much for joining us for this month's Canna Talk. We are so excited to see you all today and cannot wait to introduce you to today's special guest, Dr. Zachary Walsh. As a part of our continued efforts to share more information about clinical evidence covered in the SEC's clinical training curriculum, our webinar series, Meet the Authors, will give you a unique opportunity to experience discussion with experts in the field of medical cannabis. Our special guest, Dr. Walsh, is a clinical psychologist, a research affiliate for the British Columbia Center on Substance Abuse, and also a professor of psychology at the University of British Columbia, where he directs the therapeutic, recreational, and problematic substance use lab. He also published and presented widely on topics related to cannabis, psychedelics, mental health, and psychotherapy, and has even been the lead investigator for several ongoing studies of the therapeutic use of cannabis, including a clinical cannabis trial for PTSD and ongoing studies of the impact of cannabis legalization of cannabis use among Canadian First Nations. In today's segment, our phenomenal show hosts, Dr. Frye and Wilson King, and our expert, Dr. Zachary Walsh, will be sharing the latest clinical highlights surrounding cannabis and mental health. As a few friendly housekeeping reminders, we kindly ask that you please mute yourselves and also turn off your video just in case you need to step away. We will also be hosting a Q&A session towards the end of the show in case you'd like to learn more. Also, please be sure to check out Dr. Zachary Walsh's new course modules on cannabis and mental health, PTSD and schizophrenia, as well as cannabis and mental health, stress, depression, anxiety, and insomnia. They can be conveniently found and purchased on the SEC's website, and I'll be sure to share the link in the chat. Without further ado, I am pleased to introduce you the hosts of Canna Talk, Dr. Frye and Dr. Wilson King.
Good morning, everyone.
Welcome, everyone. Yes, good afternoon.
Good afternoon.
All right.
Good morning,
Well,
right.
Hello.
Okay.
Welcome, Dr.
So,
Walsh.
Zach, welcome.
Well, thanks for having me.
And great modules. I've really learned a lot from going through them. I'll just start off with a question, and then we'll see where we go with it. You had mentioned in your module that there were gender differences in the way certain neuropsychiatric conditions present. And how does PTSD manifest differently in women, or does it? And do you find that you see these differences in different ethnic groups as well?
Well, you know, it's a great question, and we know that there's differences in the prevalence with PTSD in terms of exposure to trauma and the subsequent development of traumatic symptoms. So women are more likely to be exposed to trauma and more likely to experience PTSD as a result. And it's the nature of the trauma also differs according to gender. So we see higher rates of PTSD subsequent to things like assaults, as opposed to in females, as opposed to higher rates associated with some accidents in males. So there's differences both in the response and perhaps a biological aspect of that related to sex, but there's also gendered aspects. First of all, in the type of trauma that people are exposed to, and I think probably more broadly in the some of the norms and the social responses to how we process trauma. So sometimes when we think about PTSD, we tend to think about combat vets, and that's been such a big piece in the cannabis world, and such great advocacy from those groups. But in broader society, that's not the majority of PTSD. In fact, a lot of it comes from accidents and from violent victimization, and those differ in ways that are gendered, in addition to potential and I think somewhat poorly understood sex differences in response to stress.
Do the patients present differently? I mean, are the symptoms similar between the two genders?
Well, sometimes when it comes to, it can sometimes follow some of those broad differences that we see with mental health more generally. So sometimes with males, we'll see more the kind of aggression and irritability and some of the anger and the expression of the anger can be different. And I would guess that that's probably gendered as well as being a sex difference. So it might be due to, just social expectations around how negative affect, irritability, and depression that come with PTSD, how those manifest. But we do tend to see more violent acting out amongst males, and then there's this relationship with partner violence that I think is also so deep when it comes to PTSD, particularly with males. So PTSD doesn't just affect the person who's suffering from it, but can also affect the family and the system around the affected individual, and that is also different depending on gender roles.
One thing I always think about when we discuss gender differences is that there's some hormonal contribution.
Mm-hmm.
With men with all their testosterone, and testosterone leads to more aggressive behavior, and women with estrogen, it's more emotional, traumatic impact, because that's where a lot of estrogen receptors are in the brain. So there's definitely biological reasons for the differences in the expression. So yeah, thank you for that information.
One thing that we do see across both genders, though, with PTSD is certainly sleep disturbance being such a central feature. And I think that that's part of the broader syndrome of things that are so comorbid with PTSD, depression and anxiety. And I think that that's where a lot of the potential benefit for cannabis lies, although we haven't been able to get at this explicitly with controlled trials, but certainly some of the cross-sectional research is suggestive that it really, one of the mechanisms for the use of cannabinoids in PTSD is in helping with sleep and in suppressing nightmares. There's been some research with inmate populations that are male inmates in Canadian jails, showing that with cannabinoid medicines, there's a dramatic decrease in nightmares and an improvement in sleep quality. And, in my clinical experience working with PTSD, that's so foundational in recovery and in improved quality of life in people with PTSD, is to be able to get that good night's sleep without nightmares, because that's such a traumatic and debilitating part of the syndrome. Is people are scared of going to sleep because they have these traumatic nightmares, sometimes more nights than not. So if cannabis sometimes can provide relief in reducing nightmares and helping with sleep maintenance, that can be huge in PTSD.
Absolutely. Well, let's move on a little bit. May is Mental Health Awareness Month, and that includes Maternal Mental Health Month. 85% of women experience some type of mood disturbance during the postpartum period. Speak of lack of sleep, there's lack of sleep, chronic pain, hormone imbalance, and other physical changes. And if you combine that with the sudden intense responsibility of a new life, that can result in significant damage to a woman's mental health. And this makes new mothers feel helpless and detached, especially when they don't have much support. Now, 1 in 7 moms and 1 in 10 dads suffer from postpartum depression. Zach, do you have any thoughts about the use of cannabis in the treatment of postpartum depression?
Well, I think based on what we know from depression more broadly, and with the DSM, when we talk about depression, it's so descriptive. So it's really a list of symptoms, and if you check off enough of those symptoms, you have depression. And if all of a sudden those symptoms aren't there, it can dip below that point where it's officially depression. So sometimes I think it's worth talking about symptoms and what are the symptoms that cannabinoid medicines can treat. And also, there's just so much stigma around cannabis use in parenting that I think it's hard to disentangle those things. So if cannabis, for some people, certainly we see reported improvements in mood. And if someone is in having a lot of negative mood or not able to find that enjoyment in daily activities of life, particularly parenting activities, and that can be a part of a postpartum depression syndrome is feelings of guilt and shame around a lack of engagement with parenting activities, particularly in dads, just feeling disconnected and like not knowing how to engage and how to get involved. And I think that, cannabis with some of its, potential for increasing mindfulness and present focus and improving mood, and maybe even just things like playfulness and engagement, I think in that way, it could be helpful, for just that temporary acute improvement of mood. When we see the research more broadly in cannabis and depression long-term, it's pretty equivocal. But in the short term, for acute symptoms, definitely people report consistently an improved mood and improved enjoyment in activities of daily living. So I think in that way, I could certainly see a role for it. But to really get at the core of that question, I think it's tough to disentangle it from some of the shame and stigma that comes around cannabis and parenting. So I think it's going to be a tough one to disentangle, but I don't see why it wouldn't be helpful for at least some of the acute mood-related aspects. And perhaps, as you mentioned, the sleep disturbance that can be part of the etiology of that type of depression. I see a lot of potential. I think for clinicians, it's about talking with your patients about how it's working and what aspects of it are working. There's so much complexity when we get it. Some of the clinical research on cannabis that I feel like where I'd like to move with cannabis and mental health is what's working for who and how. How are you using cannabis? What are you getting out of it? What are the targets? So that we can get towards a mindful and targeted use of cannabis. Most patients are pretty wise if they're cannabis users about what cannabis does. How does it work and when does it work and why are you using it, are some of the questions that I would want to focus on, particularly in that postpartum context.
That's hugely important. The reasons for cannabis use by even pregnant women as well as postpartum women is key. And one of the differences between postpartum depression and, say, major depression disorder is that in postpartum depression, there's a lot more anxiety, and that's responsive to cannabis because of the 5-HT1A receptors, the adenosine receptor pathways, and whatnot. So the anxiety, and also there's more of a fear of failure that's expressed in postpartum depression that's not necessarily expressed in depression or a major depressive disorder. So yeah, the postpartum depression does have more symptoms that are amenable to the effects of cannabis. So that's very, very helpful. One of the things that I tend to do with my postpartum patients, postpartum patients that see me now, is I use progesterone. And progesterone is really, really helpful in terms of moods, calming, allowing for sleep. If you give oral progesterone at night, and I mean progesterone, not Provera, but progesterone, it helps with sleep, doesn't knock you out so that you can't hear your baby. And if you are breastfeeding, progesterone does not get to it. Very little makes it to the breast milk. So it can be used when you're breastfeeding as well. So that's a consideration for clinicians as well.
Mm. You know, and I have worked with some men who suffer from postpartum depression, and you know, a lot of it has to do with and depression more broadly. There's that interaction between the cognitive piece, how do you think about how you're acting, and then perhaps a more biological piece that's impacting your mood and your level of engagement, your focus, and you know, and just straight up sleep disturbance can make it hard to focus. But I think the appraisal of the cannabis use is so important in that context. So if someone thinks, boy, look, what a crummy parent I am. I can't get through the day without using cannabis. That's the only time I feel okay. Or if someone's using cannabis and they're using it to numb out and you know, sit in front of the TV, that's one thing. If someone's using cannabis mindfully because it gives them a break from the repetitive anxiety and the worry, and it allows them to engage in a more active and mindful way with their children, that's very different. And that can be, you know, active. It's between active and passive coping. And cannabis is such a fluid and plastic medicine in that way that it can be both. So it's really, you know, one thing that I found as a cannabis researcher that can be so frustrating sometimes is almost everything that you say about cannabis, you could also say something else that would be equally true. So I think in certain cases, cannabis can be a parenting aid. And we're just getting ready to write up a report on how cannabis is being used in family courts. So we look through all the custody cases in over the last 20 or so years in Canada since we've had a medical cannabis program, and to see how is cannabis being used. As you'd imagine, a lot of it is a little bit capricious, where someone is just accusing someone else of being a cannabis user, and someone says, no, you're a cannabis user, and it's being, you know, custody battles can get so unpleasant in so many ways. But what really stuck out to us, when you think about things that are problematic for parenting, you know, just the direct cognitive interference or ability to make, you know, in safe choices around parenting behaviors, there's no reason, based on what we know about the acute effects of cannabis, particularly in experienced users, to think that there'd be that direct interference the way there would be with alcohol, where people are just going to get sloppy or careless or aggressive. Perhaps we don't see that with cannabis. What we didn't find in the decisions was that there was any rationale for why cannabis would be negatively related to parenting. It was just simply the stigma that someone was saying, you're a cannabis user, therefore you need to be observed. And there's some really inappropriate and I think you know, dangerous stuff out there when it comes to cannabis and parenting, with people who are medical cannabis users, authorized medical users, being caused to have supervised parenting or supervised custody if they're going to be using cannabis. And they're maybe on a number of other medications that would be more interfering, things like opioids, that are going to have a larger impact on the capacity to parent, but there's no implication that they should be supervised just because they're on opioids. But even with cannabis, regardless of dose, it seems to vary according to the level of stigmatization and I guess the prejudices of the decision makers, as opposed to any strong rationale for why it would interfere with parenting. So I think it's easy to fall into that stigma and think, oh my goodness, I shouldn't parent if I'm using cannabis. But like any other medicine, if it's allowing you to be more effective, and if the benefits are outweighing the risks, then I think it can be something that can be helpful in postpartum, but difficult when there's so much stigma around that.
Right. And the stigma is in the government and governmental agencies and all those who criminalize and disrupt families just because of the use of cannabis. Here in this country is just awful. How pregnant women are treated. There was an example of a woman who was pregnant with twins, and she had a 7-year-old, and she had, when you have twins, you have higher HCG levels, so your nausea and vomiting in early pregnancy can be very, very severe. And she wasn't able to keep anything down, and all the keep any food down. And she was losing weight, and all the various treatment options were ineffective. So she tried cannabis and had used a few puffs early in her pregnancy, and it allowed her to eat and kept her out of the hospital. But she was about to be hospitalized. And she didn't use it any more than that. And once her baby was born, because she told her obstetrician what she had done, it was in her chart. And once her baby was born, child services were called, and her life was disrupted tremendously. Fortunately, she wrote an article that was in the New York Times, and it led to city commission. It led to a lot of changes, and it was helpful. But it can be so disruptive here in this country. So we've got to really continue to work to change that. Thank you.
Well, I think conversations like this are so important, just to bring that out into the open, because, you know, there are certainly a lot of very effective and very, very straight up good parents who are using cannabis, and maybe they're even using it when they're parenting. And that's something that needs to be said.
Right. Absolutely. Patricia, where did she go? Does anyone know where Patricia went?
Her video might have kicked off. I'll email her and make sure she can get back on.
Yeah, she'll get back on.
I'll send her a quick text as well.
Okay. I will, let me move on to another question then. In your module, you talked about bipolar disease and cannabis use, and you said that there seemed to be a distinction between the medical use of cannabis and non-medical use of cannabis, and each's effectiveness on bipolar disease. Can you tell us a little bit about that distinction?
Well, you know, when we look at the research on bipolar, and a lot of it on mental health more broadly, and I think it's perhaps most pronounced when we talk about psychosis, but it applies more generally, is that a lot of the population level research that we rely on doesn't distinguish between medical cannabis users and people who may be using cannabis for non-therapeutic reasons. Mm-hmm. There'll just be some kind of, and sometimes it's very broad, it can be, have you used cannabis in the last 6 months, or is it, or, even, last year cannabis use, and that person gets put in the cannabis user group and is compared to the non-cannabis users. And then there's some inference made to suggest that the cannabis use may be consequential in the course of the illness, whereas you may have someone else who's using cannabis in a very focused way to try to treat the symptoms, and that's very different than just a group of people who are being clustered together because they have some substance use, which in the case of most of the research is going to be illicit substance use. So there's all kinds of factors that go together with using prohibited substances, and not to stigmatize substance users, but there's comorbidities with depression and anxiety. There's contact with illegal markets, and all of those things can be markers for risk, for poor prognosis in a disease course. So to extrapolate from broadly cannabis users as a group to say this is how the medical use should play out is really inappropriate. It makes it hard for us to understand those differences. It sort of gets back to what we were saying about the postpartum. It's how are you using and why? And that's really where I'd like to see the research going, as opposed to just saying cannabis, yes, no, because that really doesn't get at it doesn't help us to answer the question, especially when we have a prohibition framework where cannabis use is confounded by general, sort of rule breaking.
Yeah, and that's most unfortunate for sure. Most unfortunate. Well, since
to talk about bipolar a little bit more, though, I think we have these lower quality categories of cannabis use, and then some of the categories of the mental health I'm sure there's been many webinars done on the, deficiencies of the DSM categories. So bipolar is almost certainly a number of different disorders when it's seen in clinical practice. Sometimes it can be something that more resembles borderline personality disorder. Sometimes it's depression with a different kind of a course that sort of pops in and out. Sometimes the mania is very prominent. And I think all of those have different reactions to cannabinoid medicines. When I think about bipolar, I think it's one of the more complex issues, because if someone has a bipolar that's characterized by high levels of psychosis, then that might be a case where cannabis may be problematic. However, if it's more of a sleep disturbance and depression with a little bit of hypomania, then that's a case where it might be more akin to a depression, where cannabis could be helpful if used mindfully. So it's hard to generalize about bipolar and cannabis because of the different types.
There's so many, right, so many different varieties, and you really do have, and some of the symptoms are certainly some are more amenable to cannabis and others are not, and others, as you said, can be quite problematic. So how about we get some of the audience questions now? Do we have any?
We do have a list of questions. I can read some of these off.
There they are. There they are. Okay. Here's a question from the audience. I understand that people who go on to develop PTSD have abnormal endocannabinoid levels. Do you know if there are any endocannabinoid system lab tests available to patients and their healthcare providers, or is this still a research tool?
Yeah, I think that's going to be the next step, is when we're able to get a reliable endocannabinoid profile, perhaps at baseline, perhaps when someone is presenting with a disorder, and then see, how does that map on to the clinical profile. Most of what we know about endocannabinoid deficiencies and vulnerability to PTSD comes from animal studies. And we see that there's that one great study by Matt Hill's group looking at people who were present during the World Trade Center attack on September 11th. And they showed that, the big question with PTSD, so many of us are exposed to trauma. Some develop PTSD following the exposure, some don't. What that study found was that amongst people who did develop PTSD subsequent to this, the thing with that is people were exposed to the same trauma. So you don't know what they're coming at that trauma with, and you don't know where they were or what exactly happened. But in terms, from a research perspective, in terms of having a consistent trauma, that's probably as close as we're going to get. And they did find that people who developed PTSD showed lower levels of circulating endocannabinoids. And we certainly see support from that from animal studies showing different endocannabinoid signaling in animals who develop sort of the animal equivalent of PTSD, stress-related learning and fear conditioning. So I think we can get to the point of saying, yes, there's a role for the endocannabinoid differences in the development of PTSD, of that real big question with PTSD, and something that's certainly of interest as people are selected for military service and for other factors. What are these risk factors that make someone develop PTSD and someone else be more resilient? And when we look at what the endocannabinoid system does, certainly resilience is, I think, going to be one of the resilience and recovery are some of the top things that come to mind when you think of what's the role of the endocannabinoid system. So yes, there's definitely a role, but I don't think we're at the point yet of getting an endocannabinoid profile where we can say you're someone who's going to be at risk following traumatic exposure. But that is definitely in the PTSD research community something that we would love to be able to get at, is who is going to be vulnerable to the development of trauma, and how can we encourage resiliency and maybe have some kind of prophylactic interventions before someone goes into a context where they're likely to be exposed to trauma.
Yeah, yeah. And actually, yes, the endocannabinoid system testing is very early in its development. So once it gets to where we can actually use it in the clinical setting, it certainly will be something that we can use for a variety of conditions and disease processes. So that's something to really look forward to. Absolutely.
That would be amazing if we get to a place where we could get someone's endocannabinoids profile and then match it to cannabinoid medicines. That would really be that'll be the next level.
Okay. Another question from the audience. When you say cannabis, what are you talking about? THC, THCA, CBN, CBD, because it does make a difference.
Of course, great point. And it gets back to what we were talking about before with, we have these targets, from the DSM that are likely, not really breaking nature at the joints, as it were, excuse the pun. But, these are probably a variety of diagnostic conditions, and then we're treating them with intervention that also has many components, all the different cannabinoids. And so when I talk about cannabis, unfortunately, I'm talking about cannabis writ large, and because that's where the research is. We're not at a place where people are discriminating amongst the different cannabinoids and different preparations. We just saw that recent study come out from the MAPS funded study of PTSD, cannabis for PTSD, and in that case, they're using cannabis from NIDA, which, as we know from the group in Colorado, is not representative of the cannabis that people are using in clinical practice. It's nothing like the cannabis that people can get from dispensaries, and it differs in important ways in terms of the cannabinoid profile. It's not trivial like, oh, I like this cannabis better than another. It's not about brand loyalty. These are different medicines. So we're trying to make inferences from one medicine to another and inferring equivalence that's not even there. So I wish I was talking about distinct cannabinoid profiles and that was reliable, but the research is not fully developed, even for cannabis writ large, never mind getting at these distinct cannabinoid profiles, which I recognize are important. Having said that, a lot of the action is probably THC and CBD. So you don't want to get too granular to the point where we're not able to say anything, because you could always have the next study that's using this strain or that strain. I certainly, when we were talking about our clinical trial, I had a number of people saying, you're not using organic cannabis. How can you make any inferences there? And it's like, oh my goodness, we're trying, we really are. But we have a high THC, low THC, CBD. How many different combinations are we going to get when the research is hard to conduct in the first place? Exactly. But it's a great point.
Yeah, and the plant is so complex. We could really go off the deep end in looking at what does what, and really be so far into the weeds, I guess you should say, that we get lost and are not able to really figure out what's going on. So sometimes it's better to look at a concept or a general principle to start off with, and then maybe get more into specifics later on down the road. So it's a great question. Thank you very much for that. And another question from an audience member is, I know there's controversy about feeding a baby breast milk with THC. If a mother doesn't want to feed her baby breast milk that has cannabis in it, how long should she be advised to wait until she feeds the baby her milk? Okay, well, that certainly depends on what type of cannabis user you are, and how much fat there is for the cannabis to be stored in your body. It may be a week, it could be 10 days, certainly 14 days without cannabis, you're going to be clear. It really basically depends on the patient. Do you have any thoughts on that, Zach?
You know, as a psychologist, that's really outside of my area of expertise.
Okay.
Yeah, but I would say, you know, it's always a question of risks and benefits. We always want to say cannabis, yes, no, and I understand why people want that answer, but what are the consequences of holding off on using the cannabis? What are the potential consequences and risks of using it? At what point does it have to be zero THC in
Right.
breast milk? At what level is it reducing? What level of do we think might be harmful?
Yeah, and that gets back to why they're using cannabis.
Mhm.
Can you go without it? Is that beneficial, or does that the risk outweigh that benefit? So yeah, there's all sorts of nuances in that for sure. Another question: is a diagnosis of schizophrenia a contraindication to cannabinoid-based therapy?
A complex question again. Cannabinoid-based therapy. So, you know, there's some emerging evidence, and it's not super strong, that CBD can be helpful in reducing some symptoms of psychosis. So, if you're talking about CBD alone, and certainly there isn't evidence that CBD is counterindicated for psychotic disorders. So, if we're talking about CBD, I think it's probably pretty safe to try. If it comes to high THC, well, we know that individuals with schizophrenia often will report using THC to good effect. So I think so much of what we know about cannabis is based on what we've learned from patients that I'm very reluctant to dismiss patient reports. So a lot of people with psychotic disorders will use THC and say it helps them. So I don't want to just dismiss that outright. However, we do know that there are the acute effects of THC in some ways can mirror psychosis and can prolong positive symptoms in some cases. So people with schizophrenia, with psychotic disorders who use cannabis will often have longer relapse and you know, shorter remissions. It can cause a reemergence of symptoms. So it's in as far as things where conditions where it's not recommended, certainly schizophrenia would be top of the list where we don't recommend cannabinoid medicines. You know, but there are questions about that literature, and there's so much stigma around cannabis and madness and reefer madness, and so I'm reluctant to buy in too much to that, although I think the evidence is pretty strong that cannabis can, at least in some folks, can make psychotic symptoms, can prolong them and make them more intense. So it'd be one of the areas where I would be most cautious. But if someone is using cannabis anyhow, and they're seeking treatment, and they're saying, this is helpful to me, does telling them, no, you have to stop using cannabis or I won't see you anymore, is that going to help them? Is that walking beside them towards better health? Or do you want to talk to them about maybe cannabis products with higher levels of CBD? Or when are you using cannabis and finding it helpful? When is it sometimes worse? So I think trying to learn from the patient why they're using cannabis despite the evidence to the contrary would be the place I'd want to go, but also being open and cautioning them that the evidence is, that there's good evidence that it can be harmful for some folks with psychotic disorders.
Yeah, totally agree. I had a patient who presented long history of schizophrenia and had to drop out of school because of it. And he found cannabis and started using it. And he kept a record of his use of cannabis on a daily basis. When he came to see me, he had 5 notebooks full of daily notes on how much cannabis he was using, what type of cannabis he was using, and determined that certain chemovars were more effective. When I saw him, I went through it with him, and we learned that the higher CBD chemovars were more helpful and helped him to focus and whatnot. And that's what he eventually switched to. But this was a classic case of a patient who was committed to trying something and really was keeping a record, because he knew that cannabis was not something that was obviously helpful for schizophrenia. It's something that you have to kind of work with and determine what chemovar is going to be helpful for you. So yeah, we can learn from patients. I learned a lot from this young man, and 3 to 4 years later, he was graduating from college and on the dean's list, which was major, really major. So, and I did not discourage his cannabis use. So, very good. Another question. Does CBD have a role in the treatment of PTSD?
I think it can. It may. And when I think about PTSD symptoms and what's prominent, I think some of the what appear to be generally anxiolytic effects of CBD. And again, I want to be cautious because these anxiolytic effects of CBD have not been even conclusively determined, despite our best efforts. But having said that, there's so many people with PTSD who say that CBD or CBD alone or high CBD cannabis helps them to get asleep, and it helps some of the hyperarousal. So it improves their quality of life. If you look at that recent MAP study, and we don't want to infer too much from it, because the main outcome, they had such a big placebo effect. And I refer to the study because it just came out, and it really was a study that many of us were looking forward to. And it compared THC plus CBD to a THC, to just a high THC chemovar. And when I say high THC, this is within the realm of NIDA, but NIDA cannabis. So high THC was 12%. But nonetheless, it looked like directionally anyhow, the combination THC and CBD chemovar appeared to work a little bit better. I can't imagine, and I'd love to hear what you think, Dr. King, about this, but if someone's using cannabis, I can't imagine a situation where I'd say yes, but don't add in CBD. So I think, if you're going to use cannabis, a high CBD would be generally what I recommend in mental health conditions and PTSD notwithstanding. So I think there may be a role there, but it hasn't been conclusively determined. But what I think we do know is that there doesn't seem to be a negative consequence. CBD is so tough because we really don't have good advice around dose. I mean, the range is so dramatic that you say, is there a role for CBD? If you look at, I think some of the best stuff on CBD comes from the CREPA group out of Brazil, and they show a biphasic effect for most outcomes, where at high levels you get less effectiveness, at low levels you got to find that sweet spot. And that may differ according to different endocannabinoid profiles in the individual. So it's hard to say about CBD generally. A lot of the time, I think in some of the popular CBD concoctions, the dosage of CBD is not consistent with what is thought to maybe be effective. So it's tough to say, but I think it's worth exploring. And if patients are reporting good effects, I don't think it's worrisome. What do you think?
Absolutely. I certainly think that I start patients out on CBD. I mean, first of all, you do have to find a quality source for CBD. You can't just go buy it from the gas station store or something like that and expect to get good results. So we identify a quality source for CBD, and then start off and titrate to effectiveness. And generally speaking, it helps the cannabis naive patients to become more comfortable using cannabis, and then may be able to branch into adding THC or maybe changing the ratio, maybe getting more to a 1-to-1 ratio. Most people will do well with that. But I do find that CBD is helpful in a lot of ways in various conditions. And for those of you who are interested in that study that Zach talked about that was just released, if you look in the chat around 11:53 p.m., excuse me, 11:53 a.m., there's a link to the article that just came out. So you'll have it right there. But certainly there's a lot of different ways you can use CBD. I'm not a big fan of using CBD for sleep, but certainly for any condition that has a lot of anxiety or even moods, CBD is really helpful for mood uplifting and whatnot. So that's where I stand with that. How many more other questions do we have? Is there, oh, this is good. There is so much interest and forward motion. This is about the use of psychedelics for mental health conditions. Number one being depression. How does cannabis support or align with this new treatment option? There actually was someone the other day who they were being interviewed on a talk show and had a long history of depression and substance abuse and was getting ketamine treatment and really seemed to do tremendously well. So just to talk about some other things, what are your thoughts on that, Zach?
Well, it's actually an area where I'm getting increasingly involved. I worked on the MDMA trials for PTSD a few years back, and we're working on some psilocybin research now. And I think it's interesting how these things interrelate. I mean, is it because of the war on drugs where these diverse substances were kind of pushed together, and now those of us who are interested in looking at alternatives to current paradigms are sort of coincidentally discovering them together? Or is there really a shared mechanism? Certainly at the biological level, that the things like psilocybin and ketamine are very different from one another and very different from cannabis as well.
Mm-hmm.
But perhaps at the more subjective phenomenological level, I think there may be some commonalities in terms of I think perhaps facilitating mindfulness and a present focus. I think there's I think so many of us in the research community and our transition, like I think there's a lot of shared interest there in cannabis therapeutics and psychedelics. For me, I see cannabis as, and PTSD is one area where we see them sometimes working together. So, with MDMA therapy, which is, again, not the same as psilocybin and not the same as ketamine, but with MDMA therapy, which is showing such promise for PTSD, a lot of it is about facilitating the relationship between the therapist and the patient, so that it can take a long time to get to that level of trust where someone with PTSD is able to explore the trauma and open up with some of the exposure and reprocessing that's important for recovery from PTSD. So the MDMA can facilitate that relationship, make someone feel safer and more open, and allow them to revisit it more quickly. It might take years to develop in and out of therapy before you feel comfortable with MDMA. That can be speeded up. Does cannabis work in that way? Cannabis is more for symptom reduction, and as we said, improving sleep and maybe reducing some of that hyperarousal. Whereas with MDMA and some of the psychedelic therapies, people are going right to the re-experiencing of the trauma and having that really sort of catharsis, as opposed to maybe the gentler symptom reduction that goes with cannabis. At the same time, when it comes to facilitating trust and dialogue between therapist and client, I think cannabis is huge there. Because when patients are finding an effective treatment and they're getting shamed and sent away by their therapist, as opposed to a therapist who's saying, yeah, maybe cannabis is working for you. Let's talk about that. Help me understand how it's working for you.
Mhm.
That can go a long way to facilitating the relationship. And relationship is part of healing. It's not some sort of side thing that, yeah, make sure you attend to the relationship, because otherwise it helps you, it moves things along. It's part of the healing. So I think open to conversations and support around cannabis therapies can help the relationship. And maybe that can lead to a quicker course of treatment. But I think with this, the short answer is I think the psychedelic therapies are more almost like surgical interventions, whereas the cannabis is more about symptom reduction. So I think they could complement each other quite well, but different mechanisms ultimately when it comes to something like PTSD.
Yeah, it's actually quite fascinating how they can maybe complement each other, and that could really open up a whole new realm of therapies for people with PTSD and other mental health disorders, including depression, which is major, depression and anxiety. And with the last year we've just been through, there is a lot more PTSD out there that we're going to have to contend with. And
Oh yeah,
maybe some of these psychedelics and cannabis combinations would be extremely helpful.
Not to get too far off topic, but there's debate, I suppose. Psychedelic purists would say, oh, cannabis isn't a psychedelic. Terence McKenna was one of the great psychedelic researchers, and he, and someone asked him, and also an advocate for cannabis therapies. And people said, is cannabis a psychedelic? People's like, no, LSD, psilocybin, these are the psychedelics. Cannabis is just sort of, a trivial drug of abuse. And then he would say, if you don't think cannabis is a psychedelic, take 2 weeks off of using cannabis, smoke a whole joint to yourself, and lie on the bed with the lights out. and you'll have a mystical experience that's not so different from what you might find with something like psilocybin. So the dose makes the poison, makes the medicine.
Exactly.
I do know that many of us who are open to the idea of things like cannabis are also involved in the psychedelic space, and I think that at least there's a fellow travelers, let's say.
Yes, absolutely. I think we're getting close to finishing. What's our status here, Genesis or Christine?
It is 9:56, and we do have a hard stop at 10 a.m. So we definitely could go ahead and wrap this up now.
Oh, okay.
Okay.
Zach, it's been a pleasure talking with you. And I hope the audience enjoyed some of this as well. This was fun. This was really fun. Thank you very much. And thank you, everybody. It looks like I saw 57 participants, and it's over, almost over, and we're just down to 54. So people hung in there. So I hope that means that you all enjoyed it. So thank you. And if anyone has any questions that weren't answered, you can email either Zach or I, and we'll answer them for you, because we didn't get to all of them. I do know that, and I don't want anyone to feel like they were neglected or left out. So please email us. We can put the email addresses in the chat for everyone, and you can find them on the looking us up for sure. Okay, Janice, it's over to you.
Thanks so much. That was really a pleasure. I really enjoyed it. So I hope you'll have me back sometime.
Absolutely, anytime.
Thank you so much, everyone, for joining us for today's Canna Talk with Frye and Wilson King. We do hope that you enjoyed today's segment on cannabis and mental health, featuring our special guest, Dr. Zachary Walsh, just as much as we did. As always, we do invite you to visit the Society of Cannabis Clinicians online at cannabisclinicians.org, and be sure to explore our new course curriculum to take advantage of the latest clinical education taught by the world's renowned experts in medical cannabis. You can also find the link in the chat for your convenience. And lastly, please don't forget to donate to the SCC as the largest and longest running medical cannabis not-for-profit organization. We couldn't be more pleased to continue to offer you the latest clinical research and findings in medical cannabis. For the past 21 years, the SCC has been honored to stand as a leader in education, advocacy, and social justice. With that being said, we truly appreciate your support to help further our ongoing mission to make a difference through medical cannabis. Please donate to the SCC today. Your generous support means so much, and it helps us make a huge difference. Thank you again, everyone, and we look forward to seeing you at our next Canna Talk series, which will be hosted on Thursday, June 24th at 12 p.m. Eastern Standard Time, featuring Dr. Deborah Malka as we explore cannabis dosing. See you then and have a wonderful day. Bye-bye.
All right, everyone. Bye-bye.
Bye.